So hello everyone, I'll be talking regarding one of the most important aspect in the orthodontic clinical mechanics, that is retention and relapse. So I'll be talking a few things regarding the definition and what are different types of retainers, the theorems and the schools of thought. So basically, before knowing about retention and relapse, you have to know a little bit about the biology of orthodontic tooth movements. We all know that for a tooth to move, we need an orthodontic force that has to be applied through the braces with the help of the wire, that is your arch wire. So when you give when you move a teeth, so what happens basically, in brief to say, there is you basically have your periodontal ligament fibers which get stretched on one side. The side where the force is applied, they get compressed, and the opposite side will get stretched. So you see that where they get compressed, it's your pressure zone, that where your osteoclastic activity takes place and bone resorption will take place and the tooth will move. Whereas in the opposite side, which is against opposite direction of the force, you see a stretching of the periodontal ligament fibers, which will cause the osteoblastic formation, that is your bone formation that is taking place. So this formation of osteoclastic activity and osteoblastic activity, that is your bone formation, and resorption is your bone remodeling that takes place, which helps in your tooth to move. So as I've been telling it, it's your periodontal ligament fibers that are being stretched and compressed. So there's always a chance that when the tooth is moved, that ligament fibers which are stretched, that are in your pressure zone, which will again tend to move the tooth back. They'll pull the tooth back. So this is something which doesn't want it to happen, because it is of no use. If you want to move a teeth again, if the fibers pull it back, then what is the use of doing a treatment? That is something which, like, you're moving a teeth and then you bring the fibers are pulling it to the pre-treatment position. So there's that treatment goes on for months to years, and then after the treatment you end up again having the same pre-treatment thing, like open spaces opening, or again you see it crowding. So this thing is something called as a relapse. So to avoid it, we have to retain the teeth, basically in the position which you have newly formed. So and to be precise, until the time where this bone remodeling has completed. So that is called as your retention. So that goes to definition of retention and relapse. Basically, retention means, according to Moyer's 1973 definition, that they are the retainers, or the retention of the holding of a teeth following the orthodontic treatment in the treated position for a period of time necessary for the maintenance of the result. So you're trying to retain the teeth in the new positions which you have placed. And next, what does relapse mean? So relapse basically is all what have you achieved are lost. So it is, according to Moyer's 1973, it is loss of any correction achieved by the orthodontic treatment. And also relapse is basically, as I said, it's a slip back, or it is coming back to your pre-treatment position. For example, you are closing the space, a midline diastema, again it's opening up, you are decrowding a teeth, and again the crowding is starting to happen. So all these are here. It shows that there is a relapse of the treatment. So next, what are different schools of thought for retention? You have 4 schools of thought. One is occlusal school by Norman Kingsley, the apical base school by Alex Lundstrom, Macaulay and Nance, and the mandibular incisor school by Tweed and Grieve, and lastly the musculature school by Rogers. The first is your occlusion school. So basically, Norman Kingsley, 1880, he said that the occlusion is a most important factor in maintaining the teeth in stability. That is, in a new position, if they have to be stable, you need to have a proper occlusion, that is a proper interdigitation or the cusp-fossa relationship. Then only it is said that teeth are to be in stable position. So at the end of the active treatment, there should be a proper intercuspation and interdigitation. So second is your apical base school. According to Alex Lundstrom, it says that the apical base is one of the most important factor in the correction of malocclusion. You see that you arrange your teeth, or you move the teeth on the apical base. If not, there is always a chance of relapse. And next is a mandibular incisor school by Grieve and Tweed, who says that the mandibular incisors, the lower incisors, should be placed upright position to the mandibular base, or the apical, upright to the base of the lower border of the mandible. Upright means it should be almost 90 degrees or slightly retroclined to the lower border of the mandible. So next is lastly your musculature school by Norman Rogers. So according to it, so you know that the tooth is encapsulated by musculature in every way. For a particular tooth, from inside, as lingually you have a big muscle, that's your tongue. From outside you have your buccinator muscle and all your muscles of mastication, muscles of facial expression, etc. So a tooth is basically surrounded by all muscles which are basically in equilibrium, maintaining the tooth in position. So if there is a muscle imbalance, some kind of hyperactivity or hypertonicity, or any other muscle imbalance, that could lead to your relapse. So it has to be corrected. So that's why Rogers, he called muscles as a living myofunctional appliances. So once you treat a case, you can give some myofunctional appliances a retention so that you can keep these improper or muscular imbalances away, so that there will be no relapse. So these are the things that have to be in equilibrium for a proper stability post-treatment, post-orthodontic treatment. That is, there should be a proper rearrangement of the periodontal gingival tissues. There should be equilibrium with the oral soft tissues, orofacial soft tissues. It should be in equilibrium with occlusion, and it should be equilibrium with that of the post-treatment facial growth also. So what are the basic causes of relapse? First and foremost thing is your periodontal ligament traction. As I already said in my first slide, that whenever you're trying to move a teeth, there's always a compression and the traction or the pulling of the periodontal ligament fibers that lead to the osteoblast and osteoclastic activity and the bone remodeling that takes place. So always when there is a pull, there is traction of your periodontal fibers, there is always a tooth to come into their former position. So it could be a cause of relapse. So second is the growth related changes. Yes, so patients with skeletal malocclusions like skeletal class 2 or a class 3, they always have to be retained till their growth is completed. For example, you have seen these pictures, you have two patients where they're wearing a face mask or a reverse pull headgear, which is given in the case of a skeletal class 3, either where there's a prognathic mandible or a retrognathic maxilla, where you want to either restrain the growth of the mandible or redirect the growth of the mandible, or you want to protract the maxilla according to the case. So you give a face mask or a headgear, reverse pull headgear. So in these cases, if you're correcting the whatever class 3 relation is there, but then you're not retaining it, there is a high chance that your mandible might grow if the growth is left out and you have removed if you have debonded or removed the appliance before the growth is completed, there's always a chance again your class 3 relation, that is your prognathic mandible, might grow again and you might end up in again class 3. So it is nothing but a relapse. So always see that your growth related changes have to be taken into consideration. Depending upon, so based on that, a retention has to be given. So next is your muscular forces. I already said tooth surrounded by many muscles, so all the muscular imbalance have to be pulled away from the tooth, or they have to be encapsulated in such a way that the muscle doesn't have any force on the tooth, so they have to be removed. If not, there will be a relapse for sure. So next is your persistent etiology. Yes, again, the one most important causes of relapse is having a cause that is not removed. So the main success for an orthodontic treatment would be removal of an etiology. As you can see here in this diagram, there is this patient, you can see a tongue coming out. This is a proper example of a tongue thrusting habit where the anterior posterior movement of the tongue is causing your anterior open bite, spacing, broad arch and all, etc. So what if you're not treating the habit, directly you're treating the anterior open bite, everything, even though you give retainers and all, etc., the tongue thrust is not treated, so it keeps moving the tooth, the tongue anterior posteriorly hits the teeth, and again there's always a force on the teeth, and there will be a high chances that your open bite will occur again for sure. So the main thing here is you have to treat the habit first, then treat the dentition. So this is one of the major cause for relapse. And next is your third molars. Yes, in most of the cases you can see during the treatment you can observe that the third molars may be in the eruption stage. Most of the time they could be impacted, like in this picture your third molars are almost mesially impacted. So there is always a chance once your treatment is completed, if suppose you have now extracted a third molar, so what happens, there is always that the third molar which is mesially mesially tilted, it tries to erupt and it tries to hit your second molar, and the force goes on to the first molar, and at the end it goes on to your lower incisors. So always a chance that if you don't remove your impacted third molars after the treatment or during the treatment or before the treatment, there's always a chance the force will move mesially, the eruption forces of your third molar, and they'll all fall on your lower incisors, and you can see after the treatment you can see small amount of crowding or good amount of crowding that could happen. So the main reason is you're not removing your third molars. That's why it is one of the cause of the relapse. And next is your bone adaptation. Yes, whenever you remove a teeth, you know that in orthodontic treatment we extract the first premolars, or different, according to your treatment protocol you extract different teeth. So always when they do an extraction, the bone there is slightly calcified. So there's always a chance when you close these extraction spaces, for example if there is a bimaxillary protrusion case, you're extracting all your first premolars, and in that extraction space you want to bring all the anteriors, you want to retract all the anterior teeth to decrease the proclination and all. So what happens is, so if you haven't given a proper retention, because you are trying to move all the 60 the anteriors into retraction in the extraction space, so there's always the bone there is lightly calcified, so there's always a chance the teeth might move because of various factors, and one of it is a lightly calcified bone. So you have to give time for the bone to form properly. So for that, retainers are given. So if you don't give proper retention again, there is a cause of relapse, especially where your bone adaptation is taking place. You need to give it some time. So that completes your important causes of relapse. Now, what are the theorems of retention? So there are basically 10 theorems of retention. 9 plus 1, 9. First 9 were given by Riddle, and the last 10th theorem was given by Moyers. So the first theorem is that the teeth have to be moved, the which have to be moved, they usually return to the former position. Yes, because of the periodontal ligament traction and many other things. What happens whenever you try to move a teeth, they try to return to their former position. That is like, so it basically says that your relapse is inevitable. There is some amount of relapse no matter how much you retain also. So always see that you try to retain it in a good amount of way accordingly. So next, second theorem is the elimination of cause. I already said you have to remove the etiology no matter what habit it is or whatever. So second theorem would be, it is the elimination of cause of the malocclusion. And third is your malocclusion should be overcorrected. Yes. So as I said, as relapse is inevitable, some amount of at least 0.1, 0.2 mm of relapse could happen. So what we try to do is we try to overcorrect the treatment. For example, in this picture, it's a classic class 2 div 1 case where you have a retrognathic mandible. So for correction, they have given a fixed functional appliance to correct the molar relationship and to correct the retrognathism. What they have done is they have advanced the mandible with the help of an appliance. This is basically a fixed functional appliance. So by doing this, what did it do was, instead of bringing it into advancing it up to a class 1 molar, they have advanced it more. They bought an edge to edge bite, which is not correct exactly, but still they've overcorrected it to bring it into a edge to edge bite, and molars are almost in a class 3ish, like it's a more than a class 1, and between class 1 and class 3, it's a super class 1 relation. So I know that it's not a correct thing to bring it to an edge to edge bite, but you know that relapse is inevitable. So once they bring it to an edge to edge bite and they leave the patient, some amount of relapse will happen, and finally the patient will end up in like a proper overjet and overbite. So that is the basic logic behind overcorrecting. So next, theorem 4 is proper occlusion is important, because you know that for stability and retention and all, your teeth have to be in proper intercuspation, interdigitation. There should be a good cusp for such relationship. And next is theorem 5. Yes, the bone and the fibers, they have to be they should be allowed to reorganize or in the new position. So as you can see in this picture, so basically once you can see that the rotation that has happened, the tooth is rotated, and you can see fibers are also organized in such a way. So when you try to move the teeth, there will be a pull of the fibers everywhere. So what you can do is, once you derotate, to prevent this, you can actually cut these fibers with that of BP blade. This method is called as supracrustal fibrotomy or perisession, which is a type of retention protocol. So you can help. So anyways, if you don't want to use a BP blade, you can just give it some time for them to reorganize. So until then, you have to maintain them using a retainer. And next is theorem 6. This is nothing but your mandibular incisor school. That is, your incisor should be placed over basal bone, and they should be upright or 90 degrees to your basal bone or the lower border of the mandible. And next is theorem 7, where your corrections that is carried out during the periods of growth are likely to relapse. Yes, whenever you're trying to treat a skeletal malocclusion, especially using growth modification procedures, they are the best line of treatment, because you're trying to do the treatment during the growth, which is helpful, and you're trying to maintain it till the growth is completed. So they're most likely to relapse. So in these pictures, they have given all the various growth modification procedures using a reverse pull headgear as a face mask, needing a headgear and all. So basically these are your orthopedic appliances. So basically it's your growth modification procedures which takes place. And next is your theorem 8, that is, the farther the teeth are moved, the lesser the relapse. Yes, obviously if you overcorrect it, if the more they move, within the alveolar boundary limits, even though little relapse happens, they will be in a proper optimal position. So the farther the move, the lesser will be the relapse. And next is theorem 9. Arch form, particularly the mandibular arch, cannot be permanently altered with the appliance therapy. Yes, you can maxillary, yes, to some amount of extent you can alter, but usually the arch form is genetically predetermined. So whatever predetermined arch form is there for the patient, you can't alter it. If you try to alter it, obviously there will be a relapse. And last, 10th theorem. So the first 9 theorems are given by Riddle, and the 10th theorem is given by Moyers, which says that many treated malocclusions require permanent retaining devices. Yes, no matter what, as there is some amount of relapse that is going to happen, and you do treatment for months and years, and if relapse happens, it will be a waste of time for you and the patient both. So for that, for a safer side, for every malocclusion, it is better you give a retainer most probably a permanent retaining device. Yes, there's something which I want to discuss, a small thing regarding the retention, that you might be having a doubt. How long would you give a retention? Is retention required in all the cases? No, there are some cases where no retention is required, like which we call it as natural retention. Like for example, in case of an anterior crossbite or a crossbite, once you treat the crossbite, obviously the opposing teeth will act, or the opposing tooth will act as a barrier for it to again come back. So it's a classic example where no retention is required, a crossbite case. And sometimes you want to give a short-term retention, like example, a spacing, mild spacing case. If you want to treat, you have closed the spaces, it's you can retain it almost for a year, where until the bone and fibers are reorganized. So that's a form of a short retention. And some places you want to give permanent, or there's a long-term retention. For a classic example would be an extraction cases, or the midline diastema. If you no matter how short, if it's a short retention, if once you open it, the diastema or the midline spacing will open up. So it's better you give a permanent retention. So I've been talking about relapse till now, so I'll be talking about the appliances which will provide retention. Those are your retainers. So before that, why is retention necessary? Briefly to say, because of the elastic recoil of the gingival fibers, because of your cheek, tongue position, the habits, your differential jaw growth, your occlusal relationships, and your interarch irregularity. So that's why it's important for us to retain that new position once your orthodontic treatment is completed. So what is the timing of the tissue reorganization? Basically, it takes, for PDL, it takes about 3 to 4 months to reorganize. So supracrestal fibers takes about 1 year, and the collagenous gingival fibers will take about 4 to 6 months. So what are your retention appliances? So basically they are your fixed, they could be a fixed or a removable appliances that used to maintain the teeth in the new position, that you are the pre-treatment position, and stabilize them following following orthodontic treatment is referred as a retainer. So basically they are appliances which are fixed or removable, which will help in retaining the new positions till your tissues and the bone is remodeled or reorganized and adapted. So we have it could be removable appliances which can be removed by the patient at his or her own will, or it could be a fixed appliance which are just fixed or bonded to the teeth, mostly the palatal surfaces. So removable appliances, the ideal removable retainer according to Tony 1998 are the one which allow for the proper functional occlusion, that even the patient is meaning remove it, they should not hinder with the occlusion, they should not hinder with any form of abnormality. So they should be sturdy, yes, and they should be comfortable to the patient, should be biocompatible, they should be patient friendly, so they can wear a routine wear has to be done, and because they almost have to wear for a year, and also convenient for the orthodontist to provide and maintain. So most commonly used removable retainer is the Hawley's retainer, which was given by C.A. Hawley 1920s, and till now we use it. It's a very commonly used removable retainer. So this Hawley's retainer, it basically consists of two wire components. One is your labial bow for your it's basically both acts as an active component, also a passive or retentive component. And then for the retention of the appliance, you have a clasp. It could be an Adams clasp, C clasp, anything. And then you have an acrylic base which is connecting all these wire components. So this is a Hawley's retainer where your labial bow will be touching all the prominent surface of the teeth passively. So suppose if some moment of relapse space is opening up, you can activate this labial bow by compressing they have a U loops. So this vertical U loops, you can compress them accordingly, so that if for suppose a space is opening up, there's the relapse is happening, you can also use this Hawley's retainer as an active appliance to remove to accommodate for the relapse. And next is a wraparound retainer. As the name says, wrap around, so it's like the tooth is wrapped around, there's a wire component both labially and lingual surface of teeth, and you have your acrylic component. So in such way, there's a plastic bar which is wire reinforced along the labial lingual segment, so that it is nicely holding, all the tooth are being held. It doesn't move labially, it doesn't move lingually. And next is your beg retainer. Yes, this is also commonly used, where it's similar to Hawley's appliance or Hawley's retainer, where instead of a clasp, what they do was they extend the wire component of a labial bow. So once you give a U loop, you extend it to the most distally erupted molar, the distal side. So it curves on the distal side and it goes and embeds into the acrylic. So this is like it's wrapping around also. It's like it's also a wraparound retainer, but it was given by Begg, so it's a Begg retainer. So it was given by P.R. Begg, Percival Raymond Begg. Most commonly used in cases where you extract the first premolar, so Bimax cases. And next, your clip-on retainer or an active spring retainer, usually used if suppose some amount of crowding is happening, you can use this retainer to decrowd after treatment. And next are your clear retainers. Yes, these are your something like your aligners. So these are your S6 retainers, so thermoplastic retainers, which are obviously aesthetic. They are clear, they're just transparent. You won't be able to see them. And yeah, given by Sheridan, are pretty comfortable and inexpensive. So design, as already said, it could be of two designs, one only covering the anteriors and one is complete occlusal and all the teeth. The most commonly used design is the retainer, which is covering all your posterior surfaces and anterior, complete molar to molar. So because it helps, it will not allow the posterior teeth to supra-erupt or something else could happen. So to prevent that, it is better you form a clear retainer, use a clear retainer which is covering all the tooth surfaces. And similarly, similar to a clear or A6 retainer, you have a Klesling tooth positioner, which is similar, but it's like a splint where you have anterior, you have a thermoplastic material that spans the interocclusal space. So advantage of is no activation is required. Yes, patient has just to wear. It's like a single block, which like a bite block, like a mouth guard. And next is this, but disadvantage is always it can cause TMJ problems and some discomfort to the patient. Yes, those are your removable retainers where patient can remove, and then you have a fixed retainers which includes your banded canine, canine to canine retainer, your lingual bonded retainer, and your band and spur. So which are fixed. So as you can see, there's a banded canine to canine retainer where you band the canine to canine and you have weld and solder a wire, or you can take a coaxial wire and bond it, or to the palatal surface of the tooth, canine to canine. So this is a bonded or lingual bonded retainer. So this is how the procedure where a lingual bonded retainer is placed. First you etch the palatal surface or lingual surface of the teeth, then you prime it, you cure it, then you take your coaxial wire and adapt it according to your lingual surface below the cingulum area, and then you place composite, flowable, preferably a flowable composite material onto the cingulum on the tooth areas, and you cure it. So that's how you bond a lingual bonded or a palatal bonded retainer, fixed retainer. And lastly, a band and spur. Similarly, you band, there's a banded tooth and you have a spur which will rest against your adjacent teeth. In such way, it will retain the tooth position. So that is basically about your retention and relapse, where maintaining the tooth new corrected position is very important, and because this has to be planned prior to the treatment. What kind of retention are you going to do? It has to be planned prior, not something which you plan later to the treatment. And it's one of the very important aspect, because there's no point of treating a case if there is a relapse happening. And as I already said, a relapse is inevitable. There's always an important thing that you retain every case and most probably give a permanent retention. Thank you.